Hello everyone, I'm Dr. Rohini. We are going to discuss today about the brachial plexus, injuries of the brachial plexus. So yesterday we spoke about the brachial plexus, the nerves that arise from the brachial plexus. You know that in the head and neck region you have this cervical plexus. Then you have this brachial plexus. So today we are going to talk about the applied aspects or the clinical aspects of the brachial plexus. Now, what are the injuries that is caused due to damage to brachial plexus is what we are going to discuss today. So you can follow me on Unacademy. You can like and subscribe my videos. I have YouTube videos that is all free. And then you also have many special classes from me that is also free. So you have many things that are kind of giveaway. So you'll just get a glimpse of what you can expect when you subscribe for the plus classes. Plus classes has got everything that you need to crack your NEET PG. So you have all the material. We have a lot of MCQs. We have a lot of scenario questions. This is n number of questions you can get is scenario based questions. All this you can get from your plus subscription. That is all important for your NEET PG studies. So now you have me, that is Dr. Rohini. I have about 10 years plus of teaching experience, that is in India and abroad. I'm a postgraduate from the Manipal Academy of Higher Education, which is located in Bangalore and Manipal. And also I'm a PG educator, that is NEET PG educator. I also teach USMLE, MCI, lab and FMG courses. So you can follow me at Aqua. You can go to my profile, look for Aqua, and you can also get good amount of discount when you use my code, that is ROHINI. Please use my code to get to the plus classes. Any classes you want. It's not just my classes. Any classes you can get into by using the code and getting a discount. So if you're watching this right now, you can use this code, that is ROHINI, and subscribe to plus classes. There are very good educators. There are many experienced educators who can guide you. All right, let's move to the first thing. That is just to keep your interest going up and also to keep you motivated. So just want to tell you, you should always do what is right. So it's not that, that is tough. Maybe that is not easy. That's why I don't want to try. That is not the case. So you have to just do what is right and not what is easy. Always the easy way will be not a successful thing. So if you take easy steps towards your NEET PG preparation, so just think that you decide that you don't want to go through all the basics. You just want to do the MCQs. Just MCQs and no basics, no classes, nothing you want to read. How you just want to do some guesswork and then you crack NEET PG. I don't think it is possible. So you have to do what is right. That is not the right method. You have to use the right method and only then you can be a successful person. So this is one of the quote that I wanted to tell you, or this should motivate you to go through the videos, to note down the questions and to note down the answers, the key points, and then you know that you are in the right path. Okay, first one, before we move on to the injuries of the brachial plexus. Now you have brachial plexus injuries, but before that, what is brachial plexus actually? Okay, what is brachial plexus? You have roots, trunks, divisions, cords, and branches. Now you have this mnemonic. Yesterday, also I was talking about some topics on this. That is, are you tired? This is how you can remember. Are you tired? This you can remember this as drink, and this one as coffee, this as buddy. So if you remember this, you will go in this order. That is, are you tired? Drink coffee, buddy. That is roots, trunks, divisions, cords, and branches. It starts with the roots, C5, C6. So brachial plexus, they are formed from C5 to T1. So if there is C4 involved, then you would call that as prefixed. If it is T2 involved, then you would call that as postfixed. We'll talk about this. Before we talk about brachial plexus injuries, I'll give you a glimpse on what is prefixed, what is postfixed, and how to remember the brachial plexus injuries like Erb's palsy, Klumpke's palsy, all these. How do you relate it to the cords and branches? We'll talk about all those things today. Okay. All right, now here in this one, brachial plexus, I already mentioned it to you. It starts from C5, C6, C7, C8, and T1. So these are the usual roots that give rise to the brachial plexus. So what do you mean by brachii? The nerves that these are called the terminal nerves. Okay, these are the terminal branches or nerves that form the plexus. And they supply which part? The upper limb. This is what they supply. These are the ones which are terminal. They are not the ones which are the branches above the clavicle. They are, that is called supraclavicular. In this direction. Below the clavicular, infraclavicular. And then you have these branches. They are called terminal. So any injuries that you want to categorize, you can categorize under three groups. One is supraclavicular group, infraclavicular group, and terminal group. Okay. So if there is an injury to the terminal branches, you would put it under terminal group. So that is what you are going to learn today. The formation of brachial plexus, where does it begin? So where does it begin? It depends where exactly is the muscle. Which muscle we are talking about? The scalene muscle. We have the scalenus anterior. We have scalenus medius and posterior. So all these muscles are attached to the first rib. So first rib is an important structure in the neck. This is where the brachial plexus begins. This is the first point to remember. This is the first point to remember where it starts. So you know that they are very close to the spinal cord because they are arising from the roots. You remember it arises from the roots. So injury is actually, it is just like plucking the plant from the soil. It is just like plucking it. So the injury will be sometimes at the root itself. It is the root itself gets, pulled out from the spinal cord. So that is the injury to brachial plexus. So where it starts where the scalene muscles start. That is, they take the attachment on the first rib, and that is the first point you must remember. So now brachial plexus is responsible for both cutaneous and muscular innervation. So that is very important. It is not just muscular. It also forms a lot of cutaneous branches. For example, the musculocutaneous itself, you know, the name itself tells you musculocutaneous. So here you have muscle supplied by them, and then you have skin that is supplied by them. So now there are two important muscles in the neck which are exceptions, which are not supplied by the brachial plexus. This is an important NEET PG question. Okay, what is that question? There are two muscles which are not supplied by the brachial plexus. Which are they? One is the trapezius. The other one is the sternocleidomastoid. Now here you have this two exceptions. The trapezius muscle is innervated by spinal accessory, and area of the skin near the axilla is innervated by intercostobrachial nerve. So these two are the important thing. This is the second point, and this is the first point. So trapezius is, even though it is present in this region, in the axilla region, it is not supplied by the branches from the brachial plexus. Then it is supplied by which one? The 11th cranial nerve, that is spinal accessory. Then the area on the skin near the axilla. Now here near the axilla region, by going by the rule, it should be supplied by one of the branches of brachial plexus, but it is not supplied by that. It is supplied by intercostobrachial nerve. Okay, this is the second point. So these 2 points you must remember. This is very, very important. Okay, so next one, let's see if we have any questions. We have a lot of them. We have Rishabh saying good evening, and he is a regular, student who is always there for my classes. Next, we have positive thoughts. I don't know your name, so good evening. And then we have Sulaiman. Hello, Sulaiman saying hello. And then we have Mahesh Saini. You're always there. I have seen you. Mahesh says good evening. And then we have Anil Pant. Anil Pant also I have seen you before. And Abhay Pratap, yes, you are there again. That is nice. See, I told you, if you watch all the, YouTube videos, your 60% is covered. I'm telling you, 60% of your revision is covered if you are thorough in whatever is already taught here. Next, you have Shubham Yadav, and then we have Shane, who says presentation is good. It is loaded with useful information. Thank you, Shane. And then we have Anil Pant, who says C5 to T1. He's talking about brachial plexus, the roots, C5 to T1. Yes, you are right, Anil. Okay. Okay, next one. Now, clinical anatomy, if we look at clinical anatomy, today's class is little intense, and if you understand this, you'll be able to solve all the questions that is going to come up in the scenario-based questions. Okay, I have a scenario-based questions that is at 7:30 p.m. Then I have another one at 9:30. Which is again rapid fire quiz. So both of them, 7:31 is the, for those who have the app. So if you want to attend the 7:30 scenario based questions, you need to have the app. So if you don't have one, please download the app and then be ready at 7:30. I'm going to read out the scenario. I'm going to explain exactly what is the scenario. And just like any, medico would suggest a treatment, you can also suggest a treatment, and we'll discuss on that. That is at 7:30. Then at 9:30, we have rapid quiz on, various questions. Let's see how quickly you can answer, because you know that all the questions, they have a time limit of about 90. How many minutes? You have 90. So within this time frame, you are supposed to answer. So that is why it is about 1.5 minutes. So you have to learn to answer within the time frame. And you also have this negative marking. So it is very important that you learn this part. Okay. We have this roots C5 to C8 that is forming the lower fourth cervical and the first thoracic. This is T1, then C8 to T1. This is. Okay, it is situated between the scalenus anterior and medius muscle. This is one important thing that you might not have read before. I told you scalene muscles are attached to the first rib. And you should remember scalene muscles are attached to the first rib. And this is plexus of nerves is present between these two muscles. And if you reflect the skin, the first thing that you see is the skin platysma, then you see sternocleidomastoid, and you remove sternocleidomastoid, you will see the brachial plexus. Okay, so brachial plexus lies between scalenus anterior and medius, and then you have prefixed root and postfixed. Prefixed if the contribution from C4 is large, then you call it as prefixed, and that time you will have T2. What is postfix? The contribution from T2. So contribution from T1 is large, T2 is present, and C4 is absent. So this is one important thing you should remember all the time. So this is again an important note to remember. Next, how do you download the app? So you can go to many have asked this, where do you find this app? You can find it in the Play Store. Go to Play Store, you download it, you see this icon, you can download it. It is Learner's app. This is what you get. And then you go to NEET PG section, where you can see the various educators. You can look for me under this. You can, or else you can directly type and look. If once you have subscribed, you will get an alert of all the live classes. So you will get an alert for all the live classes that is carried out by each and every educator. So if you want my classes, you can separately subscribe and like my classes on this YouTube itself. So you have a drop down next to that. You have a drop down. You can click on the drop down and you have a link where it will take you to the Telegram group, and it will also give you a link to the feedback link and many things you can get. You can see the link to subscribe from Unacademy app. You can use the code that is ROHINI to get 10% discount. And you can also give feedback, and you can also see what are the upcoming batches that you have. You can subscribe to those batches. You can, join those batches, and then you can have a playlist. That is, I have a n number of videos already put up. You want to watch all the videos, you can just, playlist. You can maintain a playlist of all the videos. So you will get about 60% of your anatomy definitely covered. Remaining, subscribe through the classes, that is the plus classes. So plus classes will give you 100% with all the MCQs and scenario-based questions, and everything will be covered for your NEET PG. So this is something that you can do. You can always, maintain the playlist, and you can watch whenever you are free, or you can watch it again and again. Right. Next, you have so many live classes. All this will be alerted once you have this Unacademy app. So this is a lot of fun. You can also download the PDF notes you can get. This is definitely going to be helpful. Next, we'll move on to the class that we were talking about. We are talking about the brachial plexus. See the branches that you can see. You can see the first branch here now to subclavius. You can see the dorsal scapular branch. You can see suprascapular. So the ones we are going in this direction, that is above the clavicle. They're all supraclavicular branches. Below the clavicular are infraclavicular branches. Now this set of nerves that is here, they are all terminal branches. So these are terminal branches. Okay. Now, what are the branches? Now I was talking about supraclavicular. Which are they? I was talking about the branches that arise from the roots or trunks are as follows. Now you can see this dorsal scapula, long thoracic, nerve to subclavius, and suprascapular nerve. So all these belong to the supraclavicular group of branches. So you remember this one very well. This is a very important one. Very, very important because it supplies serratus anterior. This is not so, but suprascapular group of branches. Now this one is asked many a times. So does it belong to the supraclavicular branches group or infraclavicular? So now note, there is a note that is suprascapular nerve is the first important branch that is seen in the plexus when explored superior to the clavicle. So the first branch that you can see, you can go to the previous one. See, you can see so many branches here. The first thing that you can notice is this one. So the moment you look behind the clavicle, the first thing you can notice about the clavicle is suprascapular nerve. Okay, we'll go to the next one, infraclavicular branches. What are the infraclavicular? The infraclavicular branches, so many come from there. You have from the lateral cord, medial cord, and the posterior cord. So you remember this one as there are some terminal branches in the infraclavicular. Plus terminal is given here. So you have musculocutaneous, this is a terminal branch. You have ulnar, this is a terminal branch. You have axillary, terminal, radial, terminal. How do you remember this? So you can remember this with the mnemonic. This one is the lateral pectoral, musculocutaneous, lateral root of median. And then you have medial pectoral, medial cutaneous now of the forearm, and the medial cutaneous of the arm. Then you have ulnar. So remember, ulnar comes from medial cord. From the lateral cord, musculocutaneous. So you remember this. From posterior cord, you have axillary and the radial as the branches. Next one, the mechanism of injury. Let's see what is the mechanism of injury. Okay, we have Yashwant Raghav as well. So hi Yashwant, he is also there in all my classes. Thanks for watching and stay tuned. Watch all my videos and classes that is uploaded for free on YouTube and increase your knowledge. Now, mechanism of injury, it could be because of traction pull. So it could be because of someone who is a gymnast and they would have fallen on the wrong side, and that is again with the flexed neck or shoulder, and that could be something that can lead to injury of the brachial plexus. Next one, direct trauma. Something falls on your shoulder directly. So it could directly hit the supraclavicular fossa. That is where you have the upper trunk. You have the upper trunk. So that could get injured. Most of the time, direct trauma leads to Erb's paralysis. Okay, next one. Next you have, yes, Abhay, I'll tell you what is the mnemonic to learn. And I think I gave the mnemonic in the first slide itself. Can you go to my previous yesterday's class that is on brachial plexus and see what is the mnemonic? I have discussed some mnemonics there as well. Okay, next one is the C. First you subscribe and then see all the videos. In my previous videos, you will see a lot of mnemonics. So you get to see mnemonics. Definitely. Okay, next one is compression fracture. So it could get compressed on one side. That occurs when neck is flexed laterally. So that is on the affected shoulder. So this side is affected and that side it is flexed, and that can compress the structures inside or within, and it can also be tender on the outside. So that is again one type of injury. So there are three types, that is the traction type, there is direct trauma, and compression type. Next, you have this brachial plexus injuries. You have two types. One is upper brachial plexus injury. The other one is lower brachial plexus injury. So now upper one is, again, you can categorize this one. See how he has fallen from the height, and you can see how the neck is pulled. Now this one results in upper trunk injury. That is mainly C5, C6 roots. Okay. Now this one is, remember yesterday I gave you a, this is for Pratap, who just asked me what is the mnemonic. Pratap, Abhay Pratap, just see clump K monkey hangs down from lower trunk of brachial plexus. Now, which one is the lower trunk? What it gives rise to? It gives rise to ulnar nerve. That is C8 and T1. That is the root value of ulnar. So what is this one? Axillary. So in Erb's palsy, upper brachial plexus injury. In clump case, it is lower brachial plexus injury. That's why I wrote the monkey's name as clump K. Clump K monkey hangs down from lower trunk. Why did I write lower trunk? Because C8 T1 is from the lower trunk. That's why. Okay, next one. This is first thing what we have seen. Site of injury is Erb's point, and many structures arise at this thing, that is to the upper trunk it causes, and that's why this is an injury to the upper trunk. So you must remember this. Then what it causes, how it is the cause, how are the causes of injury? Now it could be because of birth injury, or it could be fall on the shoulder, and during anesthesia the plexus of nerves could be disturbed. So which one is involved? C5, C6 roots. And what are the muscles supplied by C5, C6 roots? For this, we have to just look at the root value of all the muscles. Now you have C5, C6. I would write it in the other way. I will put it in this way. C5, C6, C7, C8, T1. It is for median. C5, C6, C7, C8, T1 is for radial. So this is for the extensor compartment. This is for the flexor compartment. Okay. So both of them has everything. 1, 2, 3, 4, 5 roots. Now, only these three, C5, C6, C7 will give rise to musculocutaneous. Only these two will give rise to axillary. This C8 and T1 will give rise to ulnar nerve. So this is what happens in the so this is the one which you get by C8 T1 root, and you get C5, C6, C7 giving rise to musculocutaneous. Only these two giving rise to axillary, and all of them give rise to median, all of them give rise to radial. So now the involvement of C5 and C6 is for Erb's paralysis. Now you see which muscles are supplied by C5, C6. Before that, you see which nerves have got this root. Now, does this axillary have? Does this axillary has? Yes. What about this one? It has. What about this one? It has. What about this one? Yes. What about ulnar? It does not have. So which nerve is spared or does not get injured is ulnar. That means ulnar supplies the fingers, the hands. So hands are fine. Here, hands are okay. So what is not okay? All the other muscles. What are the muscles? We have biceps in the arm, deltoid that is supplied by musculocutaneous. That is not okay. But you have C7 that is not touched here. It is only C5, C6 roots injured. But C7 is present in this one. In this one, other roots are there. So they can still move the arm to some extent. So which one is maximum affected? The C5, C6. So what does axillary supply? Two muscles, deltoid and teres minor. So these two are completely paralyzed. I hope you understood. So these two are completely paralyzed. Rest, all of them are partially paralyzed. Now see here, mainly the biceps, deltoid, brachialis, brachioradialis, and partly all these muscles are paralyzed. Okay. Next, this is how the deformity looks like. The arm hangs by the side and it is adducted. Why? No abduction. Because deltoid is paralyzed. Very, very important. In Erb's palsy, the main thing that you can notice is the person is not able to abduct the shoulder. So extended and pronated forearm, you can see. Abduction is impossible because of paralysis of deltoid and supraspinatus. It is very important NEET PG question. Must know this. And here, it's not possible because of paralysis of infraspinatus and teres minor. All right, next one. This is how it looks. You can see that the person has adducted, and then you can shoulder is adducted and it is pronated. You can see it is pronated, right? It is not supinated, it is pronated. Very, very important. And you can see that it looks as if he's asking for some money. That's why policeman's stip hand or porter's stip hand it is known as. So this is one important thing. Paralysis of supinator muscle is seen here. That's why it is pronated. Okay, this is how it looks. You can see the dermatomes also. You can see here C3, this neck region C4. This is C5 area. This is T1 area. Only this side is C8. And here you can see C8 and C7, and thumb is supplied by C6. Very important. Very, very important. C6 is supplying the thumb region. So you can see the shoulder region and thumb region is same. C6. So this is one NEET PG question. It is applied by which nerve? The C6 nerve root. So if there is a pain that is radiating or loss of pain, it will be from the shoulder tip up to the thumb region. So loss of innervation of abductors and then loss of sensation on the lateral aspect of the upper extremity you can see when there is an injury to C5, C6. That's why the thumb. Okay, the person will definitely say that he cannot feel the sensation, loss of sensation on the thumb. So very, very important. You may be talking about so many things. You may be talking about the pronated arm, the policeman's tip arm, everything is fine. But what about thumb? Thumb, he has lost the sensation because of the dermatome. The sensation is lost because of the dermatome. So that's why in the first slide itself, we told you, it supplies both the muscles as well as the sensory innervation. So next one, clump case palsy. Clump case palsy is the lower trunk. So that was upper trunk. This is lower trunk. And you can see the nerve roots involved T1 and C8. And then you can see the intrinsic muscles of the hand. So what is paralyzed here? Hand muscles. Mainly hand muscles are paralyzed, not working. You can see the ulnar flexors of the wrist and fingers that is supplied by C8. Now let's go back to that picture. See here, this area is supplied by C8. Okay. So this area is supplied by C8 and clump K palsy is C8 to T1. See which area is T1. This is T1. So this is T1. The fingers, if you see, this is C8. So this area will be clump case. The thumb side will be the herbs. So this side, little finger side is clump case. So you can see the position of the hand, claw hand, due to unopposed action of the flexors. They are supposed to extend the fingers. Instead of extension, they are all flexed because they are not in a claw hand. There is hyperextension at the metacarpophalangeal joint and flexion at the interphalangeal joint. So now you can see this claw hand. So this is how it looks, the claw hand. So you can see the fingers are clawed and there is interphalangeal flexion. IP joint flexed. And MCP is extended. This is what happens. So you can see there is a not just extended, it is hyper extended. So it looks like claw hand. This is what you can see in the deformity when ulnar nerve is involved. This is how it looks, clump case palsy. Okay, next one, disability mainly you can see is claw hand. And then you may also see Horner syndrome. Horner syndrome, this is one important NEET PG question. You will see Horner syndrome associated with clump case palsy. Why? Why it is associated with clump K and not the Erb's palsy? Because of the association of T1 or involvement of T1 root. So, okay, because of this, sympathetic fibers are injured to the head and neck that leave the spinal cord through T1. So it's from T1 you have sympathetic fibers coming, sympathetic. In brachial plexus, you have C5 to T1. So since T1 is involved, there is this condition, Horner syndrome. So in case of herbs, you have only C5 to C5 and C6. There is no T1 here. But in case of clump case, you have C8 and T1, which is again because of the sympathetic fibers. So now, because of that, you will see the condition that is Horner's syndrome. The person will have this ptosis. What is ptosis? That is drooping. Drooping of eyelid. You can see meiosis. And what is meiosis? That is pupillary reflex is lost. Then you have anhidrosis, that is hydrosis, that is dry eyes. Then ophthalmos, that is inset eyes. So all these, I have just given you this acronym or synonym to all these words. One is ptosis, that is drooping of eyelid. When do you think the drooping of eyelid is seen? In what other condition? You can also see this drooping of eyelid, that is ptosis, in oculomotor nerve injury. In oculomotor nerve injury, you will see this drooping of eyelid because it is supplying the SO4 LR6 3, except these two. Okay, except these two, all other extraocular muscles are supplied by the third one, that is oculomotor, which includes levator, palpebrae, superioris. So remember the palpebrae, that is for eyelid. So when this nerve is injured, the eyelid doesn't stay open and it just falls down as if you have closed your eyes. That is called ptosis. And in this case, it is different. So that is different. This is different. This is because of the smooth muscle fibers. Smooth muscle fibers are the ones which are present in the tarsal plates. Okay, these are supplied by the sympathetic fibers. The sympathetic fibers supply the smooth muscle fibers, and that is what is the one which is causing the Horner's syndrome. So this is different, this is different, this is different. Okay, the injury to oculomotor nerve is also going to cause ptosis. Then smooth muscle fibers not working is also going to cause ptosis. So ptosis is not the only thing here. Ptosis is not the only thing here. You also have anhidrosis, you have in ophthalmos, you have pupillary reflex that is lost. So all this meiosis. So all this you have to list. Only then you can call this as Horner's syndrome. So there is a list of things. So you have to just go by the list of things, not just with one single, condition. Let's see if there are anybody. Okay, Shahib Maluf says there is minor and deltoid. Yes. Okay, that should be teres minor. Yes, teres minor and deltoid. It says, he says that axillary nerve supplies those two. And Shahid says pronation on the elbow joint is missing. Yes, pronation on the elbow joint is missing because elbow is controlled by the muscles of the arm. That is by musculocutaneous supply. That has C5, C6, and C7. Since C7 is intact it is. So you don't have complete loss of movement in the elbow. The person can still move his elbow. He cannot flex, but there is slight movement in the elbow. But what is maximum affected is abduction in the Erb's palsy. I hope I have made it clear, Shahib. And thanks, Abhay, for liking all the videos that I put up. So I hope I'm clear in these two topics, that is Erb's palsy and Klumpke's palsy. Let's see some more slides on the same. You have C8 to T1 results in major motor deficits. So what do you think major motor deficits? That is all in the hand. So everything in the hand. You can see the person is not able to straighten this joint. What is this called? Interphalangeal joint. This is interphalangeal joint. See, this is interphalangeal. What is this joint? This is metacarpophalangeal joint. So this is metacarpo. It is extended. And what is this? Flexed. And it is hyperextended. Metacarpophalangeal is hyperextended. So that is what you are supposed to remember in case of claw hand. Okay, that is because of C8 and T1. Mainly because of C8, you have the claw hand, and because of T1, you have Horner's syndrome. That is why clump case palsy is associated with Horner's syndrome and not the Erb's palsy. This is one important question that you must remember. I hope I have clarified this. Okay. What are the clinical features that you can see from the fall? That is, injury to the spinal cord, where the nerve rootlets are avulsed from the cord itself. Now you can say that pain is neuropathic. Pain can last for a very, very long time. All these spinal cord injuries, pain lasts for a very long time. And brachial plexus injuries occur at the level of spinal cord. So it is just like plucking the plant from its soil. So it is just like that. The entire root is pulled out. So pain can also be more distant from the spinal cord as well. Okay. So in addition to these injuries near the spinal cord, it can also give you burning and numbness sensation, and which is known as paresthesia or dysesthesia. Okay. Now, next one. What anybody can guess what is wrong with this picture? What is wrong? Anyone can guess and message me here. Okay, Abhay, brain tumor, you have to get it removed. You have to get it resolved. Or left side hand काम नहीं करता है. For that, you need to consult a neurologist. You have to go intensive, there is cure for everything. That is one thing. So there is cure for everything. Science is advanced. So sooner the better. So everything has to be addressed at an initial stage. That is very important. So if you think something is wrong, go check what is wrong first. And yeah, definitely you can update me. You can, stay in touch suddenly. Pratap can go see a neurologist. Okay, you can see a neurologist, and those people will be able to, those surgeons will be able to help you with the condition. Definitely there is cure, and since you have just experienced it, numbness, you can definitely have a remedy also from them. Okay, next one, any questions on what I have put up here slide? Axillary nerve injury. Now, what do you think is wrong in this picture? You can see that the person has lost contour over the shoulder of which muscle? Which muscle is this? This is deltoid. This looks like a person who has been working out a lot, but they lost the contour on this side because of the injury to axillary nerve. So what do you think he cannot do? So he may have numbness, that is from this side radiating towards the lateral aspect, going till the thumb region. So he may be experiencing up to the thumb. Why? Because C6 is for the thumb. So you must remember this. C6 is for the thumb. All right. Next one. So you can see that the muscle that is present on the contour of the shoulder, which makes up the, what kind of muscle is this? Is this a unipinnate, bipinnate or a multipinnate. It is a multipinnate muscle. This is a multipinnate muscle. That means it has different directions of origin. So just like feather, if you keep 2-3 feathers together, if you keep feather like this, you have 2-3 of them together, this is how it looks. So there is anterior fibers, middle fibers, and posterior fibers. And that is what forms the contour of the, and this is the insertion of deltoid. And since it is a multipinnate muscle, it's a strong abductor of shoulder joint. From 15 degree to 90 degree. This is what it does. Okay. So sensory loss is also seen because axillary nerve supplies the skin over this region. So that's why sensory loss is also seen. Okay, next one, ape hand deformity. What you can see here, ape hand deformity, you can see that the muscle mass on this area, that is thenar eminence, is lost. Muscle mass on the thenar eminence is lost. So you can see that the person will not be able to do opposition, that is counting. All this counting 1, 2. So this in our anatomy, when we mention, we call this 1, this 2, this is 3, this is 4, this is 5. Okay, this is the first digit. So here you can see there is opposition, you can count, and inability to oppose or flex the thumb. So it looks like the ape hand, this area with the elongated or stretched palm, and that is known as ape hand deformity. And this side is supplied by median nerve. How much? This 1.5 fingers. So this much is ulnar. This side is ulnar. And this side is median. And since the median nerve is paralyzed, you have a condition called ape hand deformity. Next, radial nerve. What happens in radial nerve injury? You can see that he is sitting, pressing against the armpit. That is called crutch injury. So which cord gets injured? That is posterior cord of plexus. Which are the nerves that arise from there? One is axillary nerve, the other one is radial nerve. So here what happens, since the radial nerve is present on the posterior aspect, it emerges down, it goes downwards. Axillary would go upwards to supply the shoulder joint. Axillary will go upwards to supply the shoulder. Radial comes downwards to supply the backside. So that is where it gets injured. And that results in loss of extension. Loss of extension. So it results in a compression of nerve on the brachial plexus. Now you can see that the person has hand that would be pointing downwards, and that is known as wrist draw. It is known as wrist draw. Okay. Okay, now we have one last slide. Last slide, this is serratus anterior. So serratus anterior, anybody knows what is the nerve supply to serratus anterior? The nerve supply to serratus anterior is long thoracic nerve. It is from the long thoracic nerve, is also from the upper trunk. Upper trunk branch it is. So it is having the same C5, C6, C7 as the root value, just like musculocutaneous nerve. And what happens when it is injured? It supplies the serratus anterior muscle, which is also called the boxer's muscle. It is also the nerve which does this muscle that does the extension on and the abduction, that is from 90 to 120 degree. This is called overhead abduction. That is called overhead abduction. So you lift your arm in 15 degrees. 0 to 15 is by supraspinatus. 15 to 90 is deltoid. And you go over the head is 90 to 120. And that is done by serratus anterior. So now you can see that the action of the serratus anterior is to rotate the scapula. It is for rotating the scapula when you lift your arm in an upward direction. But what happens instead of rotating, it is winged out. It is out. It is not put towards the thoracic cage. It should stay put towards the thoracic cage. Instead of that, it is standing out like a bird's wing. And that is known as winging of scapula. And how can you test the patient? You can ask him to do some push-ups, or you can ask him to push the wall like he's doing now. By looking at his serratus muscle or looking at the scapula itself, you can identify this is normal. This is not normal. And the antagonist to this serratus is rhomboidus muscle. And what are these muscles? They are one of the accessory muscles of respiration. So serratus helps in lifting the rib cage, because you have 8 digitations. Okay, you have 8 digitations. You have 1, 2, 3, 4, 5, 6, 7, 8. So you have 8 digitations of serratus anterior muscle. So it is coming from the rib here, and it is going to the medial border of scapula. So it will help in rotation in this direction. So this is the glenoid cavity where the humerus will take the incision. This is how it is. So it will help you in rotation of the scapula, and it has 8 digitations. Since it is attached to the ribs, all these are ribs, it can help you in elevation of the ribs. So it is an accessory muscle of respiration. So as the accessory muscle of respiration is serratus anterior muscle. So with this, we come to the end of the session. So I would expect all my viewers to kindly subscribe. And please, before you leave, hit a like so that I can put up more and more videos. Your likes are very important to us. So if you have liked our videos and if you have subscribed, we get to stay and put more videos on the YouTube. So you can subscribe, and each one of it's just like voting. If you vote for me or if you subscribe to my classes, then it will definitely help me and motivate me to put up more videos on various topics. You can also send me the list of topics that you are actually looking for. So the topics that you find is interesting or it should be discussed in depth, that can also be done. So you can also subscribe to the plus classes for lots and lots of activity. So I'm going to end the class at this, and I look forward to meeting you all at 7:30 with some more topics, that is scenario-based questions. Again on the brachial plexus. Let's see, whatever you have understood, whether you can solve that or no, we'll see at 7:30. That is, if you have a Unacademy app only, because it is a class that is a special class that is called. So if you want to attend the special class, you need to have the app Without the app, you cannot get a reminder. You cannot attend the class. So those who have the app will be able to have unlimited access to all the special classes. Okay, thanks for watching.